Otherwise, she has been here on the ward for the last 3 months. She has been here on the ward. Yeah. Leaving her family at home. They have these kind of deadly diseases, but affording the treatment is a problem. Most of our children on this ward, they come from very poor backgrounds. I should say like 95% they are below the poverty line.
It is actually a highly curable tumour, provided they have the right chemotherapy. And of course chemotherapy over 6 months costs approximately 100 to 200 euros. But the majority of parents bringing their children to the Cancer Institute can't actually afford that much for chemotherapy. And I think it must be absolutely unimaginable to be a parent and to be told that your child has a curable tumour, but to find that they're going to die because you can't afford the medication for them.
Like out of 10 children, you can save like 2. So it's just a matter of time. Eventually they die.
Once a small fishing village, the southeastern city of Jinja has benefited from being located on the trade routes between Kenya to the east and Uganda and Rwanda to the west. It lies beside the source of the River Nile, and locals say that it takes 4 months for one drop of water to meander the 6,695 kilometers north to Egypt and flow into the Mediterranean Sea. Outside of the city, in rural areas, people like these sugarcane farmers survive on subsistence farming and trading in local markets. The average household income is about €6 a month. Access to healthcare of any kind is difficult and mostly unaffordable. With this in mind, Hospice Jinja was founded in 2005 to meet the palliative care needs of patients with advanced cancer and HIV/AIDS.
Like the rest of other hospices in sub-Saharan Africa, we focus on cancer patients and also on the terminally ill HIV and AIDS patients. And right now, as we speak, 55% of our patients are cancer patients and the 45% are patients with HIV and AIDS.
The Jinja Hospice was started with the help of local and international fundraisers and supported by people like retired Irish doctors Frank and Patricia Hassett. The size of the area the hospice covers is vast, so they have developed a unique system of community volunteers to help identify those who are in need.
We go to the village and we talk to the village leaders and we ask them for the community to choose people who they would like to help them if they were sick. So 2 or 3 come from the village and they come to a special training course in which they learn basic nursing skills, how to care for patients in the home, how to make the bed over a patient who can only lie on the floor and things like that. So it's very practical. But they're also taught when to refer patients to us which are needed. The patients who are in severe pain, patients who they suspect have cancer or have HIV. And we will meet them once a month to see if they're having any problems and to give them continuing education. They don't get paid, but if we have a donor who will give it, we are able to give them a bicycle after 3 months of good care.
Once identified by the volunteers, hospice staff visit those who are too ill to attend the outreach centres in the rural villages.
Mr. Sulaiman Chinavi has been on the hospice program for the last 3 years. He was diagnosed with the cancer of the breast, and since then we have been taking care of him. By the time we met him, the disease was already advanced, and the best way was to palliate his symptoms and challenges that we were going through. I'm asking him to tell us how he is today. So the bleeding is controlled from the tumor, but it produces some fluid. Number 2.
But ever since hospice started treating him, they really help us. They give him good treatment. When sometimes Mzee can be there crying, saying that I'm feeling pain, but the treatment, it's very good.
So when asked about his pain, he says his pain when he takes the oral morphine is controlled, since he does it 5 times a day, and he was explaining to us how he does the 5 times. When we met him, the tumor wasn't as big as that, but as we say that the cancer is continuing to grow. But in the first case, his major problems were pain and a foul smell that he was getting from the tumor.
Okuwunanga wena mpigano buli kuwulira ngera bwoba wano bulido singano liku singeni ndo ojikole.
When asked about the foul smell from the tumor, he says if it were smelling, every one of us would have been. So, but it's not there, and so it is also well controlled.
We call them family members. The way how they treat us, the way how they take us, they don't take us like people who are maybe patients. They take us like family members.
Unlike Hospice Kampala, the local government imports the morphine powder. Due to inefficient administration, the teams face running out of morphine on a regular basis. The doses are carefully rationed, which can frequently result in patients running out and suffering extreme pain for days.
One of the problems that people on the ground face is the supply line. Sometimes money is available to purchase drugs when there are no drugs. Sometimes the drugs are available and there's no money. And the consequences are very bad for patients who can suffer immeasurably when the drug is just not available on a given day.
Florence Nandogo is 46 and has been diagnosed with a nasopharyngeal cancer.
When she had the oral morphine that we gave her the last week, the pain was controlled and she was able to eat some food. But now, 2 days, the oral morphine ran short. She no longer has it, and so the pain is back in full swing. So we straight off give her a dose of oral morphine to help her to kill the pain straight off. No, it's okay. They are asking her about the nose bleeding, and she is reporting and saying that after we met her last week, after that time, the bleeding became very severe, and it was too much that she thought maybe she was going to die then. And thank God it's later reduced on its own, and now she's having kind of bleeding still, but like the normal that she usually experiences, a little bit just. The levels of prognosis are also determined by what other treatment options you take up. So assuming maybe she had had a radiotherapy, as she was suggested 1 year ago, maybe she would be a little bit better. So it seems she doesn't have a lot of time left.
For most of the people that the hospice cares for, radiotherapy and chemotherapy in Kampala is geographically and financially out of reach. Eventually they die, leaving family and friends behind.
After a person dies, the remaining family are bereaving and grieving the loss of their loved one, and it's really important that they receive support. And that has always been a feature of palliative care, and it's equally a feature of palliative care in Uganda. So typically after somebody dies, the team will go out and visit a few days after the funeral to offer their condolences to the family. And it's really a way of sharing their loss. And people find it very supportive, and again, I think find it really helpful that team would take the time to come to them. I think it helps them to feel that the person who's died was very valued by the team, and that they themselves are valued by the team, and they derive a lot of support from that.
This is what we call a bereavement visit. We come and share a moment with the family, and we ask how the patient was before he or she passed away. And we also bring in our condolences as hospice and the team. And so we came along with other patients, and so they can also be able to sympathize with the rest of the family.
Dr. Anne Merriman has established a model of hospice care now being implemented in countries across Africa.
And it's a huge achievement because, as well as setting up services that provide direct palliative care and setting up high-quality services that are affordable, an education system has been set up that has trained over 17,000 healthcare professionals since the hospice started in the 1990s.
This new education centre provides training to healthcare workers from Cameroon, Malawi, Sierra Leone and Sudan.
Now, all the doctors who qualified since 1994, they know what we're talking about. But we also started teaching in the nursing schools, training courses for health professionals, for traditional healers, for spiritual advisors. And we see the future of palliative care as being carried forward by those we train, not by our own service.
The World Health Organization has made it clear that morphine is an essential drug for cancer pain relief. What we see in Africa, as in many other parts of the world, is that many problems and barriers in getting access to morphine. Although it's a cheap drug, it's easy to produce, and it's relatively easy to administer in trained hands. At the moment, many people who would benefit from it are not receiving it. Uganda has demonstrated superbly that you can overcome these problems, that you can prescribe morphine, you can make it available to those who need it without it being stolen, without it being diverted into the wrong hands. It provides reassurance that this can be done in countries with very small resources otherwise.
The World Health Organization says that chemotherapy and radiotherapy won't be available in Africa for generations.
there is hope. One of the really exciting things that's happening at the moment is the idea that we can start to think about freedom from pain and access to pain medication as a fundamental human right. A number of lawyers, philosophers, activists of various kinds are working towards building up a case for the recognition that freedom from pain and access to pain medication is a human right. This is a much more powerful argument than we've ever had before, and it's getting listened to in places where palliative care was previously ignored.